Today what we're going to do is we're going to be looking at the issue of disease prevention and immunizations. We're also going to be looking at the issue of exemptions, which I think are creating a real challenge for public health officials here in California as well as around the world, and also a challenge for communities, which are trying to protect the most vulnerable in the communities from infection. As a pediatrician, I know that meeting these challenges will require a strong relationship between families and their physicians and their other healthcare professionals. Today, this relationship competes with the internet and other sources of information, which sometimes is credible, but sometimes may not be. And without that strong relationship, the patient-doctor relationship, the patient-health professional relationship between families and physicians, sometimes the damage that can come from misinformation cannot be undone. As many of you know, back in 1998, there was an article published in The Lancet that was a study of 12 children that claimed that there was a potential link between vaccines and autism. This study then prompted some subsequent, more significant research that showed that this link did not exist, and later was found that even the original data from this study was actually discredited in terms of its source. But unfortunately, the study and the impacts of it still live on in the internet and the media. And in fact, if you go onto the web, you're still going to find numerous articles and testimonials of based on that particular study, which has now been retracted by the Lancet, saying that that there's a link between the measles vaccine and autism. And I think that with these sources, more and more information. And I guess I shouldn't say information, more and more things on the internet and other places that sometimes it can be very confusing. And I understand as a parent myself of two young children, always looking for trying to find accurate information, and we're all trying to do what's best for our children. But too often it can be very difficult to sort out accurate and inaccurate information, and often there are there will be misinformation that's cloaked as science or other things that end up in the web. And that's why I've introduced Assembly Bill AB 2109, which is going to ensure that parents are provided with accurate immunization information when they decide if they're going to potentially consider an exemption from their children from being vaccinated. California has passed immunization requirements for school by huge bipartisan majorities of the legislature. People have recognized the important public health protections provided by immunizations. We also know that in 2010 there was a pertussis outbreak, and that the threat to epidemics to California remains very real. It's not something of the past, but something we still have to face in the present. And that we do know that also that when we allow parents to exempt their children from being immunized by simply writing a pre-written statement, that we are by lowering immunization rates, we are opening our communities at higher risk for infectious disease and epidemics. So I'm hopeful that AB 2109 and the dialogues like that we're having today are going to strengthen the relationship between families and the medical community, that this bill is going to ensure that parents are able to have that discussion with their healthcare professionals to learn that accurate information, that this will be the key if we're able to help schools and communities maintain what we call herd immunity that will save lives and prevent outbreaks. And I'm certainly pleased to have here today some of the leading experts on how we can help build a healthier California and build a healthier world for our children. So thank you so much again for being here. Yeah, video. Right. Bye.
Thank you all for being here. By the way, my name is Catherine Martin. I'm director for the California Immunization Coalition, and I just wanted to share a video, one of our projects with the coalition called shotbyshot.org, which is a compilation of stories of vaccine-preventable diseases, families' experiences, mothers, fathers, grandparents who decide to share this with the community to tell them about their lives and their stories. This is Gavin's story.
Having Gavin was like my dream come true, to have that fourth boy to kind of complete us, and also to honor my brother, that, to name him after him. It was a really significant time in our lives, and to be completely transparent, probably the happiest time in our lives as a family. It was just really a wonderful, joyous time for us. We decided to go to visit family on the U.S. mainland in Utah. We live in Hawaii, and so it was a big, exciting adventure for us. And before we left, I took Gavin into the doctor just because I wanted to make sure we had the green light go. Because he was so young, I wanted to make sure he was safe to travel. And we had a great Christmas, and right after Christmas, Gavin started coughing, just occasionally. One cough here, one cough there. A few nights into that, we got a little bit more concerned than we had been before, and we decided to take him to the emergency room just to be checked. He hadn't been eating well, and so I was worried about dehydration. So when we got to the emergency room, I truly was just believed that we would give him some fluids maybe and that they would send him home. But when they decided to admit him, I was very surprised. They told us to expect to be there through the weekend. So we spent a few days there, and there really was no change in his condition. In fact, he seemed to be getting a little bit worse. It was just a few days after that he still was not improving, and they transferred him down to the Pediatric Intensive Care Unit, or the PICU. They had gotten a positive test result, which indicated pertussis. And from there, it was a very quick decline. He was very ill, and it was fast, and it was terrible. We watched him die from pertussis. We sang to him, and we spent as much time right at his side as we possibly could. And my husband put his hand on his chest and was just feeling for those last beats of his heart. And within moments, he was gone. We left the hospital with empty arms, and it was a really terrible thing. We left, and we had to leave him there and go back to the reality that we were not whole, and we had to go and tell our sons that their brother wasn't coming home. And that was a terrifying thing to have to do as a parent, to go and tell your sons that their brother is dead. And it was a tremendously difficult time for our family, and continues to be.
Thank you, Kathleen, for showing that video. I think that's a good start. My name is Dr. Dean Blumberg. I'm Associate Professor of Pediatric Infectious Diseases at UC Davis Medical Center. And I'd like to welcome people here on behalf of the California Immunization Coalition and thank Assembly Member and Dr. Pan for calling this legislative briefing. It's an important subject. I'm going to start by giving an overview of the vaccines. And I think that video just calls to mind cases that I've seen with pertussis or whooping cough that it's heartbreaking. It's heartbreaking. Kids cough, and they can't get breath in. And as a physician, there's only so much that we can do to save them, and sometimes we can't save them. And the kids who are most vulnerable to pertussis are those who are the youngest kids. And those are the kids who can't be protected by vaccines. And so that's where we do rely a lot on protecting them by protecting those around them to try to decrease their chances of exposure so that they don't end up in the ICU and so that they don't die. So vaccines are important both for a public health reason as well as personal individual health. Vaccines are given in order to prevent infections, and they're given, they're manufactured by either taking part of a microorganism, a pathogen, or modeling a part of that to which we need to be immune to, or weakening it, significantly weakening it, so that it's still alive but not able to cause disease. We administer these to children and adults, and then the immune response that results ensures that if there's a challenge from the real pathogen in the future, that our own immune system is able to fight these infections off. And these are quite useful for several different reasons. And one is, of course, the diseases they prevent and some of the consequences of the diseases. So they'll prevent individual diseases, and they'll prevent some of the outcomes of these diseases, including some infections cause cancer. So now we have vaccines that actually prevent cancer. And it's really wonderful to see that. Now, we've got these vaccines, and they protect individuals, and that's great. But what's also nice is what Assemblymember Pan mentioned also, herd immunity, which is there's extra bonuses from these vaccines, which is if you can immunize a significant portion of the community, then what you end up doing is decreasing circulation of the pathogen. And then even those who aren't vaccinated or may not have had a very good immune response to the vaccine, they're still protected indirectly because then they're not exposed to the disease as much. And so this has resulted in exponential reductions in diseases, and we've had several examples throughout history. We've eliminated smallpox, that's the most dramatic example, but significant reductions in terms of paralytic polio, pertussis, although we had the resurgence in 2010, that's still markedly reduced in the pre-vaccine era. And one of the most dramatic examples in California is with hepatitis A vaccine, where we vaccinated a minority of the population and had a dramatic reduction in the transmission. These diseases. And on the other hand, it's a way to address public health. And in terms of addressing public health, our vaccine schedule is cost effective in that every dollar that we spend on vaccinating children, routine vaccinations, we do end up saving money in the long run. And because of this, this is clearly important as public policy with our current difficult fiscal times. And one of the things to remember about vaccines is they don't protect 100%. Nothing protects 100%. And I like to give the example of driving, where you can be a very safe driver, you can wear a seatbelt, you can make sure that your car you're driving is in good condition and that you have airbags. But even if you're the best driver in the world and a safe driver and alert and not impaired, if you get a drunk driver coming at you, you can still die in a horrible car accident. And it's the same with vaccines. You can do everything right, but they don't work 100%. And that's why it's important to maintain a level of immunity within our community to try to decrease chances of exposure to pathogens. And here is where personal belief exemptions are critically important, because these diseases are still with us, they're still around, and people who choose to have personal belief exemptions, which have been increasing in California, it means that their children remain at risk of disease, and then if they get disease, they're at risk to transmit to others, even those who are immune. So they can be a potential danger to others. Now, we all want parents to be able to choose what they want to do for their children and choose what's right for their children. And if some parents are educated on the subject and they feel that vaccines aren't right for their children, well, we're not a communist country. We're not forcing anybody to get anything. That's their decision. But what we do want to make sure is that parents do take this decision seriously, because it is an important decision. And that's why I think that your bill, AB 2109, is critically important, because what it does is make sure that parents address the issue of vaccination. If they have any hesitancy at all, we want them to make sure to address that with somebody who they trust, with their child's health care provider. And this just assures that they do take this decision very seriously and that they do address this. So we will be hearing later on this afternoon more about vaccines, about vaccine safety. We're going to hear more about what it's like on the front lines to talk with parents about a sometimes difficult subject, as parents sometimes have strong opinions that are outside of the scientific medical mainstream. We'll also hear about the public health impact of vaccine and vaccine policy and why the schedule is the way it is. And then we'll also hear, I think, what's critically important when it comes to the personal belief exemptions is how they do tend to cluster. And even though they are at a relatively low rate overall, the clustering in certain communities leads to locally high rates of personal belief exemptions. And these specific communities then are very vulnerable to outbreaks of disease. So at this time, I'd like to turn it over then to Dr. Sawyer.
Good afternoon. I'm Dr. Mark Sawyer. I am an infectious disease specialist from the University of California, San Diego School of Medicine. And I too would like to thank Dr. Pan for organizing this briefing, in which we're going to cover a wide variety of topics related to immunizations so that people go away today with a better understanding of the whole process. And the portion of that I'm going to cover is to give a quick overview of how vaccine recommendations are made and what we know and how we know that vaccines are safe. So I'm going to quickly go through the various groups that are part of the decision process to recommend a vaccine. And it begins with the Food and Drug Administration, which is charged with the responsibility of approving new vaccines based on scientific studies that show that they're effective and show that they're safe. Followed by that, the Centers for Disease Control, largely through a committee called the Advisory Committee on Immunization Practices, makes recommendations for the use of those vaccines that have been approved by FDA. And I happen to be on that committee now. I've been on it for the last 4 years, so I'm going to share with you a little bit of the behind the scenes of that committee so that you can understand the depth with which these recommendations are reviewed before they're formulated. After that, each state, in our case the California State Department of Public Health, makes specific recommendations within California to certain groups for use of vaccines. The professional associations, American Academy of Pediatrics, American Academy of Family Physicians, American College of Obstetrics and Gynecology, all of the professional groups make recommendations to their members. So this is an independent review of the data behind recommendations and independent endorsement of what vaccines should be used. Following that, individual healthcare organizations, hospitals, managed care organizations, and PPOs, in some cases, make specific choices of what vaccines to use and which ones not to. And then ultimately, the final decision is between an individual healthcare provider and a parent or a patient. And that's where that decision really belongs. So the rest of this is to support that interaction so that providers have the best information to discuss with their families. So now a little bit about the ACIP, that's the Advisory Committee on Immunization Practices. This committee is a national committee with expertise in public health, infectious disease. There are physicians, there are nurses, there's a community member on this group. And this group is charged with taking recommendations from FDA and deciding how those vaccines should be used. Anytime a new vaccine product is licensed or a potential new use of a vaccine is brought forward, the ACIP formulates a work group. These work groups include national and international experts in the disease and in the vaccine. And those work groups spend, in general, between 1 and 2 years reviewing all the scientific data behind the disease and the vaccine, its efficacy and safety. And they summarize that data and present it to the full ACIP for discussion in the formulation of recommendations. Now, so that you don't think that ACIP works alone, there are formal advisory or liaison relationships with all of these organizations. I don't expect you to recognize the acronyms, but these are AAP is American Academy of Pediatrics, for example. So there are physician groups, there are infection control groups, there are representatives from government agencies like the VA system, the Indian Health Service, from HRSA, from the National Institutes of Health. Each of these groups has a representative who attends the ACIP meetings and has an opportunity to share their expertise and their opinion about a recommendation before it gets formulated. And as you can see on the right-hand side of that slide, we actually have international representatives as well, representatives from Canada, the United Kingdom, and Mexico, who share their expertise and experience with vaccines. So the point I want to make in going through this is that once a recommendation is made by ACIP, it has been very thoroughly reviewed by a very large number of individuals. The considerations that we look at in recommending a new vaccine include the burden and risk of the disease in the community, the effectiveness of the vaccine, the safety of the vaccine. And I can tell you that vaccine safety has become elevated in the importance with which we review it, even more so in the last decade. The cost-benefit or cost-effectiveness of the vaccine, the feasibility of introducing a new vaccine, the cost and reimbursement situation, and finally, patient and parental preferences with regard to new vaccine. So So it's a very thorough and rigorous system. Now I want to spend the rest of my time discussing how we know that vaccines are safe. I know parents have concerns about vaccines. We're giving more vaccines now than we ever used to. For me, that's a great thing because I don't see the infections that I used to see in the hospital. But for parents, it's a big decision. They have a lot of information to digest. So there are a number of reasons that we can be confident in the safety of vaccines. First of all, if you just literally look at the numbers, we give millions of doses of vaccine every year in the United States, billions of doses worldwide, and so any unusual side effect will eventually become evident simply because of the numbers. We give vaccines to more individuals than we do any single medication or any other health intervention that goes on. So as a result, we've learned the most about vaccines. Beyond that, there is a vaccine safety infrastructure that's been built up over the last 20 years, which is extremely robust at finding side effects from vaccines. It begins with the Vaccine Adverse Event Reporting System, or VAERS. That's a reporting system I'll go into in a little detail that allows anyone to report a suspected side effect. The Vaccine Safety Data Link, which reviews the likelihood that there's a real relationship. And I'll go back over this. The Clinical Immunization Safety Assessment Network, or CISA, and the FDA and CDC. Each of these groups is designed to cover an aspect of vaccine safety. So let me now just go through each one of these quickly. The Vaccine Adverse Event Reporting System is organized by CDC and FDA. It was developed in 1990, and it is a system in which anybody, a parent, a friend, a relative, a doctor, a hospital worker can report something that they suspect is an adverse event from a vaccine. And this allows us to constantly monitor safety of vaccines through reports from the community. The next structure I want to describe is the Vaccine Safety Data Link. This has also been around for 20 years. This is a linkage of 8 large healthcare organizations, including Kaiser here in California. And through the strength of the ability to share electronic health records of millions of people who receive vaccines, this system can quickly identify and study any suspected side effect, anything that's reported in the VAERS system can quickly be evaluated in millions of people, which is something that we never were able to do before. So this has been a very strong enhancement of our vaccine safety infrastructure. The CISA network is a group of experts in vaccines and immunology who then take any documented side effect and try to understand it better. Why does it happen? Are there certain groups who are susceptible? How can we prevent those side effects? Next slide. So in summary, the recommendations for the use of vaccines are based on the best science, and they are very carefully formulated. We're being reviewed by literally hundreds of experts before they are created. Vaccine safety is extremely important in that process and is monitored constantly, and can be comfortable with the safety of vaccines. And in fact, I would make the case we know more about the safety of vaccines than we do any other health intervention. Okay, with that, I think I'm going to turn it over to Dr. Talarico from the California Department of Health.
Good afternoon. Can everybody hear me? Great. So I'm John Talarico. I'm the chief for the immunization branch for the California Department of Public Health, and I again want to just thank Dr. Pan for inviting us here for this briefing. And I'm going to talk, I have two issues to talk about. One is basically the surveillance and the vaccine-preventable diseases that occur in California, and then to talk a little bit about what we've heard briefly mentioned, which is herd immunity and why that's so important, and about some of the clustering of PDEs in California. Thanks. So one of the things that Dr. Sawyer mentioned was that they look at how effective a vaccine is, and in fact, our vaccines have been very effective, so much so that I think it's to their detriment, because nobody is remembering at this point the children paralyzed from polio or dying of diphtheria in this country that really was only happening 40 or 50 years ago. So the current vaccines really have controlled the majority of infectious diseases in the United States, many of which used to terrify parents, including smallpox, tetanus, measles, mumps, and Haemophilus influenza disease. Right now, of all the vaccine-preventable diseases, smallpox has been completely eradicated from the world, and others are very well controlled in the Western Hemisphere. The ones that are controlled, but in the U.S., but are still prevalent and causing deaths in other parts of the world include measles, where there's about 540,000 deaths worldwide. Haemophilus influenza disease, tetanus, and diphtheria, where there are still 4,000 deaths worldwide happening. So the point is that when vaccines are delayed or stopped, herd immunity is diminished, and these diseases can come back very quickly. And also there's the potential, the airplane there is to remind me that there's always a potential that because these diseases are not controlled in other parts of the country, that they can be reintroduced into the U.S. and into California. And I will talk a little bit about that later. Next. So the reemergence of previously controlled diseases has already happened in Europe. As Dr. Bloomberg mentioned, in 1998, there was a study that came out that tried to link autism with the measles vaccine, which was later repudiated. But really, the confidence in some of the European countries has never fully recovered. But right now, there are enough susceptible people to sustain epidemics. And there were over 30,000 cases of measles in Europe last year, and 15,000 of them were in France alone. So you can see that when we stop immunizing, these diseases come back, and they come back with a vengeance. Another example is in the former Soviet Union, which formally dissolved in 1991. And just 4 years later, they were having diphtheria epidemics with 4,000 deaths that occurred during an outbreak 1 year. This is just to show you that these diseases are still happening worldwide. Go ahead. So in terms of California, I think everybody here is probably aware that during 2010, California had a pertussis epidemic, and there were 9,000 cases, or over 9,000 cases of pertussis. And this was more than has been seen in the past 60 years in California. This included 10 infant deaths. And so there were a lot of things that we did during that year to try to raise awareness. And in 2011, we still had an increased number of pertussis cases, but we had no deaths last year due to pertussis. But in 2010 and 2011, there were over 1,000 cases hospitalized. And most were in infants less than 6 months of age. And the important point here that has already been brought up is that these are infants too young to be fully immunized against pertussis. The epidemic happened probably because there was a large enough pool of susceptible people that had accumulated in the population, because we have a large birth cohort, so they're all unvaccinated and susceptible. There is waning immunity after either vaccine or disease. So there's some thought in some of the communities that, well, get the disease because then you're protected. But with pertussis, that is absolutely not true. You still have waning immunity even if you get the disease. There are vaccinated people who have a vaccine failure, and then the parental choice not to vaccinate children. So I'll go on to another disease that we haven't heard a lot about because pertussis has kind of eclipsed this, but in measles, in 2008, there was a 7-year-old child who had a personal beliefs exemption. They were infected with measles in Switzerland and returned to San Diego County and sparked a measles outbreak. Now, the important thing here is that the child attended a school with a 10% PBE rate. And 12 of those children were infected, or 12 children were infected during that outbreak. 9 of them were children who had also had PBEs. 3 infants were too young to be vaccinated and were infected in a clinic waiting room, and 1 infant was hospitalized. So again, the idea that measles is a rite of passage is not true. It can be a very serious disease. Go on. Thanks. In 2011, there were 28 reported cases in California. The age range was 11 months to 68 years. 17 had known links to international travel, and that's why I'm saying that these can be introduced back into our population very easily now. And they're not the countries who we used to think were the countries that would expose us. These are France, the Philippines, India, England, Italy, Thailand, China, and Malaysia. So the idea that you're going to go to Europe and come back and that it's perfectly safe is not one that you can really make. The vaccination status of these cases you can see that 18 were unvaccinated. So again, if you're unvaccinated, you're at risk. But also notice that there were 4 that were vaccinated. As has been said, nothing is 100%. And so even if you're vaccinated, there is a small chance that you are not going to be protected against the disease. In the United States in 2011, there were 223 reported cases, and this is the most since 1996. So we are seeing a rise in these imported cases and sustained transmission in the U.S., at least briefly. Another example of vaccine-preventable disease outbreaks that are being sparked or started by people who are unvaccinated is just recently in 2011, there was an unvaccinated student with a personal beliefs exemption. They were infected with mumps in England. They came back to the UC Berkeley campus and sparked a mumps outbreak. There were eventually 29 mumps cases that were associated with that outbreak. And about 3,600 students received the MMR vaccine as a booster to try to get their immunity up and prevent transmission. All in all, there were 43 mumps cases reported in California that year. And the last example that I want to talk about is a child in Humboldt County who was in a family, all of which were unvaccinated, against chickenpox or varicella. All of the children in the family and the pregnant mother became infected during that time over a 5-week period. The mother was actually very ill. Several siblings attended the same school and were a source of a school outbreak. That school was a K through 8, and it had 174 students. Again, of note, almost 40% had PVEs. There were 22 additional cases of varicella identified, and 86% of them were those who had taken personal belief exemptions. But again, not all of them. Some had actually been vaccinated. So I won't go through the rest of that, it just kind of details who had vaccine and how many doses, except to say that a pregnant teacher was also infected, and that we have about 100 school-based varicella outbreaks per year in California. Go on to the next. These were just additional slides that talked about how many cases worldwide, again, to show you that vaccines really are very effective here in the U.S., and where they're not used, these diseases come back with a vengeance. Thanks. And we'll do questions afterwards. Thanks. How am I doing on time?
Great.
Good. Okay. So, I think, oh, here we go.
You can introduce yourself now.
So the next topic I want to talk about is where the personal belief exemptions are here in California, a little bit about those, and a little bit about herd immunity. Go ahead. So there, this just shows a map of how many states have personal belief exemptions versus religious exemptions by state. As you can see, there are not a lot of, well, it's a very difficult, I guess it was green. So the states in green are the only states that have personal belief exemptions. The rest either have a religious exemption or no exemption at all, except for medical exemptions. Go ahead. And this graph is just here to illustrate very quickly that the yellow dotted line there is showing what the personal belief rate is in California over a period from 1978 to 2010. And as you can see, right about until 1998 or so, that was fairly constant at about 0.5% or hovering right around there. The red line, the red dotted line, are permanent medical exemptions. And you can see they have remained constant over the entire period. But in 1998, you can start to see that we have some increase in the personal belief exemption, and actually that begins a pretty rapid rise. And that slope of that line, if you look from probably 2006 or 2007, is going up really quickly. This just shows where these personal belief exemptions are by county in California in the year 2000. And so you can see green basically means you have a very low level of personal belief exemptions, and progressing up yellow, orange, and red shows you where the rate or the percent is higher. You can see in 2000 It was mostly the northern counties, with a little bit to the east of us that had, or the east of California had higher rates. Go ahead. And so this is showing two things. On the left is the actual number of children who have personal belief exemptions in 2010, and on the right again is the percentage rate, so it's comparable to the previous slide. So the reason for both of those being up there is that in Southern California, even though the rate is kind of medium, you can see there are a lot of number of children who have personal belief exemptions, and that's important because the absolute number is really going to help determine how quickly something will be transmitted from child to child or from person to person. You can go to the next slide. And this is just a comparison. On the left is 2000 and the percentage, and 2010. And you can see on the left, in 2000, we had a lot of green, a little bit of yellow, and just a little bit of orange, and only a little bit of red, which is the highest rate. To the right is 2010, and you can see that there's hardly any green, and that we have really shifted much higher. And you can see where this lies in California, and that these are tending to cluster. You can go on. Thanks. So just a little bit about what we know about personal belief exemptions. This is from a summary article in the New England Journal of Medicine. So as they looked at PBEs throughout the United States, they saw that really those who took PBEs, those parents thought that really children had a low susceptibility to the diseases. And that's probably due in part to the fact that vaccines have been very effective, so they don't see the diseases. They also thought that the severity of the diseases was low, probably again due to the fact that we don't really see those diseases anymore. They also believed that the efficacy and the safety of vaccines was low. And this is probably more due to some of the misinformation that Dr. Pan was talking about and that our other presenters talked about. And really, the most frequent reasons cited for non-vaccination by about 70% of the parents was concern that the vaccines might cause harm. Now, we've just heard really how thoroughly vaccines are explored in terms of their safety before they're recommended. So this is concerning that is a perception out there in the minds of parents. Go ahead. So we did see that in the graphs that the personal belief exemptions do tend to cluster geographically. If those 2%, we have an overall rate of about 2.5% of personal belief exemptions in California. If they were equally dispersed throughout the state, we would probably not be seeing what we're seeing, which is these outbreaks with transmission. The fact is that they do tend to cluster together, and it's really not fully understood why. Perhaps it's that people of similar beliefs go to similar schools or congregate in similar areas, but we do know that they do cluster. We also know that variation in school policies, as well as the belief of the school personnel who are helping parents fill out these requirements or exemptions, is really key for compliance with immunization requirements. So I want to switch gears here just because I've kind of been alluding to it and we've heard about it, but this chart just basically shows you what we observe with vaccines and vaccine safety and loss of confidence in vaccines. So to the left, you can see that pre-vaccine, we have a disease and the disease rate is high, indicated by that blue line. And we have the vaccine introduced, and that's the green dotted line. And as we see the vaccine coverage goes up, what we expect if the vaccine is effective is that the disease comes down, which it does. Now, we also there are adverse events to any medication. Aspirin has an adverse event. So we do have a small amount of adverse events, and they really remain pretty constant. But as the disease drops down further, people don't see the disease or the outcome of the disease, but what they do see are adverse events. So in their mind, there's a loss of confidence in the vaccine. The green line then drops, which is vaccine coverage, and when that drops, we see outbreaks of disease, which then people say, there's disease, it's severe, we ought to get vaccinated. They get vaccinated. But this cycle tends to repeat, and it's been done in Germany, Japan, and other countries where this happens over and over again. Go ahead. And this chart is kind of explaining what our previous presenters were talking about. This kind of is the concept of herd immunity. The oval there represents the population or the herd. In that population, we have the green, which are people who have been vaccinated. We have the red person there who is somebody who can't get a vaccine because either they're immune compromised or they've had a true contraindication to the vaccine. So they're susceptible to disease, but they're there. Then we have the yellow, which are those who are too young, like the children who died of pertussis in 2010, those 10 infants. And then we have the blue there, which are vaccine failures. So those are people who think that they're protected, they've done everything right, but they don't know it, but they are actually susceptible to disease. Now the concept is that as long as there are enough green people in that little oval, that if one of the yellow or the red or the blue becomes infected, that they aren't next to somebody else who's susceptible. But once we start to have those people who either have contraindications, which is not going to go up, or those who are too young, which again is not going to go up, but those who are either vaccine failures or what's not represented is those who are intentionally unvaccinated. Once those go up, then we can have efficient transmission. And transmission will occur between anybody who's susceptible, not just those who have taken a personal belief exemption, but those who are too young, those who might be immune compromised and can't get a vaccine, or those who are a vaccine failure. So this is just a chart that shows you the level of vaccine coverage that is needed to keep transmission from occurring. And for diphtheria, it's 80 to 85. For Haemophilus influenza, luckily for us, it's pretty low. But you can see for measles, mumps, pertussis, even polio and rubella, those numbers are pretty high, at around 90 to 95%. So that means once coverage drops below 95%, we can start to see outbreaks. And the 2008 outbreak in San Diego, that one school had 90% coverage because 10% were PBEs. So you can see that this pretty much holds true. Go ahead. So high vaccine coverage, particularly at the community level, is extremely important for the reasons that I've just talked about. Now, this next key points are just saying that there have been multiple studies that really have looked in different communities in Michigan and Colorado about, is it really true that where you have high exemptors, you have resurgence of disease, even on a small level, on a community level or a school level? And each of these really says yes, that the likelihood that you're going to have increased disease or be at increased risk for disease if you have a high PBE rate, it holds true, and this just gives you some of the numbers for what those are. So in 2008, again, just this herd immunity concept, due to a drop in immunization rate to about 80 to 85%, which is lower than that 95% needed for measles, measles was again declared endemic in the UK, meaning that it is no longer under control. It's there and present in the community at all times. And this just shows you that that's true for Canada and for other parts of the world. So, I'm sorry, this was just a reiteration of the Humboldt County varicella outbreak, where we had that large outbreak of varicella in those who were in a school that had about a 40% PBE rate. So in summary, PBEs are easy to obtain and are on the rise. They're clustered, and therefore they pose a risk to both the child who has the PBE, but also to others in the community. And that parents who utilize a PBE may have firm beliefs opposing vaccine, or they may be hesitant because of unfounded safety concerns, or they may be taking them for some convenience factors. And there was, again, a study published in 2006 that really showed that the ease with which you can obtain an exemption really indicates that you're going to take them more often, and that the rates rise more quickly than those who have PBEs but have a little bit more education and procedure around taking a PBE. Yes. Great.
Thank you very much. Dr. Bergen and Dr. Pakuda.
to be part of this briefing. Thank you all. My name is Randy Bergen. I'm a pediatrician, both a general pediatrician and a pediatric infectious disease person from Northern California, Kaiser Permanente. So I kind of bridge the world between the consultant and the primary care doctor. In fact, part of the reason I'm late today is I had 2 newborns whose parents had a lot of questions for me before I could leave Walnut Creek and leave my office. So you've heard a lot of excellent, very succinct presentations so far, talking about some of the specifics about vaccines, vaccine safety, some of the issues around outbreaks and personal belief exemptions. And honestly, my presentation is I think, is as much a reflective kind of presentation as it is anything that provides extra data necessarily. You can go on to the next slide. I want to emphasize that from my perspective, the issue of personal belief exemption is a huge issue, but it's only kind of part of the issue of the larger issue of vaccine refusers. From the point of view of a practicing pediatrician, it's not just the school-aged children, it's not just the middle school children, but it's also the newborns that I have concerns about not being fully vaccinated. So when we talk about the world of personal belief exemption, it really is a slightly larger world than perhaps this bill is going to address. So I want to kind of emphasize that to you. And it's because of a variety of things. Some parents refuse specific vaccines. Others want to go more slowly in terms of the vaccinations and never really quite catch up and get all the delivered vaccines. So there's a variety of reasons. And over the course of the last few years, I've really kind of struggled with why that is. I've had many discussions with parents, loving, caring parents that are bright, that want to do the best thing for their children, but yet, in my opinion, aren't necessarily making the right decision. And I think to some extent this is kind of a generational decision. We have a speaker that often comes to Kaiser to talk about how we relate between the generations. I'm a boomer, of course. And one of the comments he makes, he usually begins his presentation with a slide showing his daughter holding up a 9th place ribbon for a swimming meet that she was attending. And just kind of hitting home that the way that we now as parents, and I have 2 wonderful stepchildren and 2 wonderful children that are between the ages of 16 and 20, and they have been raised to believe that they are special. And their parents did the right thing, encouraging them to believe that they were special. But I think sometimes we go perhaps a little bit too far in that. Often this speaker then turns to the boomers in the group and says, and did your parents ever say that you were special? And if so, it probably was more of a sarcastic kind of, oh, you think you're special, do you? So I think there is kind of a generational thing. And as I think about it, I think that the issue is more that so many parents can't come to the grips with this potential 1 in a million risk of a vaccine. That somehow the sins of commission are worse than the sins of omission. And it's partly because, as has been mentioned by other speakers, we've done such a good job with vaccines in the past. That there are so few cases of these vaccine-preventable diseases anymore that people have forgotten about them. And as Dr. Tallarico shows with this graph, when we start to not vaccinate, then the outbreaks come and the diseases come back and people kind of change their opinions. So as I kind of struggle with how we address parents on this, I think this is one of the key learnings for me. And I think it just makes it so important that a bill like this gives us another opportunity as a pediatrician to make a touch point to these parents, to give them the opportunity once more to hear from us the importance of how important that we feel these vaccines are. And no disrespect to public health officials or people in the community, but I still believe that it's that personal connection that you have with a physician, and that physician giving you advice that is often what makes the difference between decisions that parents make. So if I might kind of go to the next slide, what we're specifically doing at Kaiser, this is an issue that really over the last decade, to some extent, kind of caught up with us. We were noticing a drop in our immunization rates over time, but it really wasn't until about the last 5 years, about the time that we began to use an electronic medical record, that we really began to look at this more thoroughly. And we're just really in the process of kind of digging up some of this data, being more specific in terms of our diagnostic codes. But in terms of the whole issue of vaccine refusers, so the larger issue of all children that are not fully vaccinated, either unimmunized or underimmunized, we find that in our medical centers, the rates are somewhere between 5 and 15%. There are medical centers where some of these pockets that Dr. Tallarico talks about with, where the epidemics have often been caused by. The rates are sometimes as high as 15% of children not fully vaccinated. So this is a real major problem, and again, we're trying to kind of address some of these issues and trying to kind of be more specific in terms of seeing whether we can direct specific educational initiatives towards specific vaccines and how we kind of promote specific vaccines, especially that are under-immunized. But this is an increasing problem that I think all pediatricians face, and as a result of that, we're seeing these outbreaks. The final thing I wanted to address, there have been a number of studies that you've already been exposed to, a lot of data. I'm not going to go into extensive detail about this study, but this is a Kaiser study that was presented by one of my colleagues, Dr. David Witt, who works in the San Rafael Medical Center. So this is an outbreak situation that occurred in 2010 with pertussis. He presented this data that he collected with a number of his colleagues at one of the most influential infectious disease meetings in Chicago last year. And then he'll be presenting it again at our California Immunization Coalition Summit. So if you want to hear more data, actually Dr. Witt will be attending that summit, and I encourage you to talk with him. I won't go into the specific details, but I think that the study really demonstrated 3 very specific things that I think are very germane to our discussion. Number 1, most importantly, the epidemic of pertussis that occurred in Marin County in 2010 was an epidemic that was centered and started and perpetuated in the schools. So as school-age children that were primarily the ones who were getting infected, primarily passing this infection on to their other students, to parents, to siblings. It was the school setting. It was that elementary and middle school setting where the epidemic was occurring. The highest number of children that were affected were the children that were 9 and 10 years of age. 2 other important issues is there was a significant percentage of children within those schools that were not fully appropriately immunized to pertussis. And again, that's the idea that if there are more susceptible individuals, you fall below a certain threshold, even when the other children are vaccinated, that they're not as well protected. And then the final piece that was found in this study is there were significant children who were just about at that cusp. The individuals that were 9 and 10 that would be close to the age that we would want to give booster immunizations that actually seem to be the most commonly getting infected. So that I leave to Dr. Sawyer and here's peers on NACIP to review this data and to look at other data to see whether we should make revisions in our vaccine recommendations. But these were children who were fully vaccinated according to our recommendations, but immunity was waning. As a result of being exposed to so many susceptible individuals, that epidemic was maintained and really spread throughout the community. So the benefit of a bill like this that you're proposing, I think, is really immense. Again, it gives us the opportunity to touch these families one more time, to emphasize to them the importance of giving these vaccines, and it can make a huge impact to the individual children and to the children of our communities. So thank you for the opportunity to give you my reflections and opinion.
I guess I'm up next.
Awesome. Do yourself there.
My name is Dr. Bob Benjamin. I'm Deputy Health Officer with Alameda County Public Health Department. I've been involved in communicable disease control through public health for 30 or maybe more years. And I'm indebted to everyone here for presenting the material that's gone forward. So the question that I think you should be asking is, so what happens in public health when a communicable disease is reported? And there are, I think, 81 or 82 diseases in the state of California, which by law are reportable. All of the vaccine reportable diseases are. So when we in public health, and forgive me, I don't have slides, power went out almost 2 days, day and a half ago at our offices. Computers all went down, so I'm going to wing this. I'm going to do it the way the boomers do it. So we get a call for reporting a vaccine preventable disease, and the most common of which are, of course, measles and mumps and pertussis. It's almost as if we're in a fire station and the fire alarm goes off. Basically what we do is, at least within communicable disease control, we've got to drop everything and find out what's going on. The first rule of thumb is first confirm the diagnosis. We don't want to go running off to a false alarm. That's where we begin. There may be other specimens that need to be obtained, either blood, nasopharyngeal swabs, sputum specimens, stool, urine, depending upon the disease. We've got to go do that. We've got to confirm with the laboratories that, in fact, the data and the laboratory tests upon which this diagnosis is based are true. Then after that, the real work begins. What we do is something called case contact investigation. Upon notification and confirmation of a case, we send someone or several people out to the home or homes of the people who have been reported to us to see if we can identify when the disease onset was, where the source of infection might have been, and to whom the infection might have been transmitted. Because our job in public health is to prevent any further our job is to prevent disease, full stop, and that's why we rely on vaccines. And what we've gotten is very, very compelling evidence and information about how personal belief exemptions really impede that. But once a disease has come to our attention, our job is to stop transmission cold. It's not so easy to do. I'm looking at the clock, and I know that we're kind of jammed. So what I'll do is go through very quickly. So we interview patients, and we find out that they're in schools. We find out they're in workplaces. We find out who their social contacts are, who their friends are, who their relatives are. And then we go and investigate those people, and we assess their immune status. In schools, this can be a huge job because, we had an outbreak of a disease that happened not to be vaccine preventable just last year in a high school with over 5,000 students. Assessing immunization status is very time-consuming, and more than that, what it does is it diverts our workforce. This is a huge labor-intensive effort. And if I need to say that twice, I will later on. Because what happens in public health when these diseases, we have either single cases or outbreaks, is huge numbers of our workforce then have to be diverted to deal with these situations. In a school situation, actually, I'll just skip through to one of the ones that was mentioned. I think Dr. Tallarico did. The most recent mumps outbreak at UC Berkeley. What had to be done was, as soon as the cases were reported to public health, the health officer had to sit down and devise a plan of action, figure out how to implement that plan of action, identify contacts to the student who came in who happened to be intentionally non-immunized and decide whether they were truly exposed, and if so, they had to be excluded from class until one incubation period has gone by so that they don't bloom with the mumps and then transmit. We had to identify the people who were cases, and it turns out that in total, by the time the outbreak was over, there were 29 cases, and exclude them. Next step was, what's the prevention? What's the preventive measure? And I think there were, 4,300 doses of MMR purchased by the state. 3,700 actually got into people. But think about how difficult it is and how labor-intensive that is to organize those kinds of mass immunization clinics. Because UC Berkeley sits in the city of Berkeley, and the city of Berkeley has its own health department, their resources were pretty quickly overwhelmed. And what they needed to do was request mutual assistance from neighboring counties, from Alameda, from Contra Costa, from San Francisco, from UCSF schools of nursing and pharmacy, in order to get this job done. Very difficult task. It took almost 3 months to quash that particular epidemic. So what are the costs? I think, John, you presented the San Diego outbreak. That one cost, I wrote it down. The San Diego one cost about $180,000. San Francisco in 2009 had 3 cases of measles. It cost them $98,000 to deal with that and to shut down transmission. So I've sort of presented what we in public health do, and I've left out a lot, believe me. In very broad brushstrokes, attempted to give some cost figures. The mumps one in Berkeley, in working with the Berkeley City Health Department, we're up to somewhere around $200,000 to contain that outbreak. But there are other costs that are not monetary. They're not workload. They're costs to the community and to the society. The costs of kids missing school. The costs of parents not being able to work because their kids have been excluded from school. The cost of parents not being able to work because their kids are ill. These are not insignificant costs. And so now I'll wrap up quickly. In thinking back on this analogy that I began with, of a fire alarm going off in a fire station, it occurred to me that individual decisions, like personal beliefs, have ramifications far outside the household. An example, if you'll bear with me, a fire example, is that the decision to get rid of the shake roofs on your houses and replace them with fire retardant shingles or tile may seem like an individual decision. You can either do it or not. But the decision to do it and or the decision not to, just like cleaning the tinder and shrubbery around your house so that you have a defensible zone against fire, it may seem like an individual decision. But if you opt not to, it has huge community ramifications. I live in Oakland. You may or may not remember we had a little fire some years ago. The decisions of individuals to take action to protect themselves or not have vast ramifications in the community. So that's sort of a brief overview of public health burden. the burden of these diseases to public health. Thank you. Yes. And here's where the rubber meets the road.
Is this working? Can you hear me?
Is the button pushed?
Yeah. I think I picked one that doesn't work.
Come over here.
Can you switch places? Thank you. Is that better? Okay, I hope so. Hi, I get to wrap up at the very end here. My name is Pascal Fukuda. I'm a general pediatrician. I'm in San Francisco. I love my job. I have been able to watch children grow from 0 to college, and actually I have 4 patients who I saw as teenagers, not as babies, who have now become parents and are coming to the office. So I'd like to talk about the relationship that we have in the offices when we see our patients and the families that come in and out. We talk about everything from when you're a baby to your teen years to trying to get to college. And we talk about when you're well and when you're sick, and what can you do to prevent things, and what can you do once you're sick to treat them. And in all of those discussions, there's the discussion about the medical science of what we're doing and what will that do for your child, so that I can make a decision to help those families to make an optimum decision, whether it's treating an ear infection or giving a vaccine or breastfeeding or what kind of solids or allergies. We have that discussion every single day. I think the other education piece about medical care, and specifically to vaccines, is in the communities, is what you're hearing about. The preschools and the schools, the burden on the teachers and the school staff and the nurses is unbelievable on a day-to-day basis with all the kids coming in and out. All the sports teams and camps just want to keep the kids safe and healthy so that they can enjoy their activities. The community centers where not only children go, but adults and the elderly as they are participating in different events. And the public areas in the parks and in the zoo, going shopping to the grocery store, all areas where we want to be able to function our day-to-day lives and be able to live life to its fullest. And we need to educate our healthcare team, which is involved in the whole process as well, all the people who work in the clinics and the hospitals, and all the wonderful people that are in the health department. And we have to work together to deliver messages to our community so they understand about their medical care. So I'd like to just tell you, you have heard many statistics and seen graphs. I think that's just the tip of the iceberg, because I have a couple of stories I'd like to tell you that were not reportable, but true stories that happened in my practice. I got a call from Alice, who's a teenage girl who's in her school swim team. They had just gone up to the state championship. Half of the team members of her class came down with whooping cough. All of those members were in high school in different classes, so they all went to their classrooms and not only exposed their schoolmates, but also their families, including their aunts, uncles, grandparents, and friends. The whooping cough vaccine, tetanus and whooping cough, was introduced in 2005, and this was a couple years after it came out, and not as routinely given. The health department came in to take care of the fire, swept in to vaccinate everybody who was not immunized, and Alice rushed to my office to get immunized, and the discussion about if she needs antibiotics. Hopefully this scenario will not reoccur, thanks to AB 354, that as of 2011 to 12, children in high school will now be protected because you'll need to get into it for 7th grade. So I bring that as an older child's story and her community. I also want to talk about a family. 6-year-old Bobby and 3-year-old Charlie, and had a new baby sister, Debbie. Mom was finally in a good group because Debbie had decided to sleep for at least 6-7 hours a night, and she had 2 more weeks of her maternal leave before she had to go back to work. Her job every morning, which she was beginning to enjoy because she was getting some sleep, was to bring Bobby to kindergarten and then Charlie, who's 3 and a half, to his preschool. And of course, she had to bring Debbie with her to drop off all her children. 2 children in Bobby's class in kindergarten decided not to be vaccinated and came down with whooping cough. The mom brought the children in. 6-year-old Bobby had finished all of his shots, and we said we would just watch him. 3-and-a-half-year-old Charlie was a little too soon to get his 5th dose of DPT, which you give between 4 and 6, but I reassured mom probably he was going to be okay. The worry was with 1-month-old Debbie. She was too young to be vaccinated. We prescribed antibiotics, as is recommended, to prevent her from getting whooping cough. Of course, in a week, she developed a cold. And mom and I talked every single day for a week to see how she was doing. And luckily, after about 10 days, her cold symptoms went away and we breathed a sigh of relief. She will start kindergarten this year, and mom and I still have the discussion to this day. So I really want to emphasize our job as being on the front line, whether you're a specialist, whether you're in the health department, or a general pediatrician seeing the kids coming in and out, that we'd like to work together so we can stay healthy in our families and communities. And of course, I'm from San Francisco, so I had to show a kid.
So I would like to just quickly summarize, give you an overview of the information and the themes that we heard today, starting with Dr. Blumberg, who introduced the concept of herd immunity and how that is so important and central to this story, and that was repeated in many of the presentations. He also reminded us how cost-effective vaccines are as a preventive health measure, and in the era of dwindling health resources, that can't be overlooked. I hope I summarized for you the thoroughness with which vaccine recommendations are made and the vast infrastructure we have in place in this country to study the safety of vaccines so that we can assure our patients that vaccines are safe when they're being recommended. Dr. Tallarico reminded us of the history of the success of vaccines and how many young parents have totally forgotten the devastation that vaccine-preventable diseases are capable of. But he then also reminded us that outbreaks are continuing to happen, and that reminds us of the importance of vaccines, outbreaks of measles and mumps and pertussis. He also mentioned this concept, which I don't think we've spent enough time on today, about parents opting out of immunizations for school entry simply because of convenience. That it's easier to just exert a personal belief exemption of school entry than to find the immunization record to document that their child's immunized or go to the physician's office and get them immunized. And that's a main target for this proposed legislation, is to avoid convenience PBEs because this is such an important issue. Dr. Bergen and Benjamin both illustrated that this is an increasing problem and that it has a very big impact on our community, on our public health structure, and it is a costly problem. And lastly, I think it was great that Dr. Fukuda finished up with some personal stories about what this really means one-on-one between physicians and families as they go through the decision to be vaccinated and the difficulties that people face when they're exposed to vaccine-preventable disease. So it's very important that we remain vigilant, that these diseases are still here. They will come back if we let immunization rates fall. And to summarize, my personal feeling about vaccines was best summarized by the Surgeon General at the end of the 20th century, David Satcher, who said vaccines are the most important public health intervention of the entire 20th century. So with that, I think we'll wrap up, and I appreciate everybody's attention today. I hope we shared some useful information as we go forward in the discussion about this legislation and other issues related to immunization.
Catherine, are we going to allow anybody to have comments? Or
Yes, please. We have some time for questions.
I have a particular question. My name is Steve Barrow. I'm the Executive Director of the California State Rural Health Association. We represent hospitals, rural hospitals, rural clinics, doctors, communities, and community leaders. Looking at Dr. Tallarico's slides of where the problems arise, you can imagine our association and how interested we are in looking at this. There are a couple of issues that come up in talking about personal belief exemptions and having parents go back and have a conversation with their physician. One is we've already had discussions in the rural areas about the cost. I'm going to lay out a couple questions and I'll let you then answer. One is that there's a concern of the cost and whether it'll be reimbursable. Because one of the problems we have in the rural areas, a lot of things are not being reimbursed at a rate that will help us keep the clinics and hospitals open. And this is, so that question is on the landscape, and so answering that. Second question is, when I was not this last January, but January 2010, I was back in Washington, D.C. at a rural health conference. And I have 6 kids. I have 3 older kids by early marriage, and I have 3 kids in my current marriage. The kids that I have in my current marriage are 6, 4, 2. Well, some of you on the board who sit on the CIC board with me will remember I was back there and my 21-year-old daughter was living with us at the time. And started and had developed a really nasty cough that kept getting worse and worse and worse. And she was living with us. She was also working in a local restaurant. And so our 2-year-old was less than 1-year-old, and so not vaccinated. And I got a call that the baby had started into this kind of a whooping cough. Well, I'm in Washington, D.C., my wife's here, and so I immediately contacted those of you on the board, Mark and Dr. Blumberg and Bill Mason, to ask them some advice because I was going to take a day to get back. I left the conference, came back. So this leads to a question, because when I got back, I had to go to my 21-year-old daughter's doctor with her because they were refusing to test her for pertussis, even though they knew she was living in a household with a less than year-old baby. She was tested eventually. As those of you who know me, I'm pretty good at insisting and advocating. And finally got the doctor to get her to go ahead and have the lab test done. She did have pertussis. We had already isolated her from the baby. The baby's cold kept getting worse, but like the one that Misako was talking about, the baby got better, turned out not to be pertussis. Daughter, 21-year-old, had pertussis. Pretty frightening time for us, because knowing the little bit I know because I work with you folks. So one question came up, so a second question, what is the reimbursement rate on counseling parents? The second question is, it really took a lot of effort to get a kid tested because there wasn't a huge outbreak in Yolo County. That's where we live. There was an outbreak, there were some cases, but it wasn't really big, so there wasn't a fire drill done. And yet, even though I told them that my daughter works in a restaurant, was a waitress. So that's the second question. The third question is that I used to work as the governmental affairs director for the Children's Advocacy Institute, which is based out of a law school down at USD, but ran this office here. I suspect that most of the parents who are taking PBEs now, personal belief exemptions, are vaccinated themselves. And it seems to me that one of the things we're dealing with here is that they're not respecting the rights of the child to be protected against diseases that could be extremely harmful to their lives and their, even if they just got really sick. But it's not respecting their right, even though their parents have respected the boomers' rights and got them vaccinated. And I was wondering if Dr. Tirorico, if there's any research in how many of the parents taking PBEs are also vaccinated themselves, and they're kind of, in my way of thinking, that is really a crime against their own children by not respecting their rights but protecting them from the same disease their parents protected them from. So there are 3 questions on the table.
Okay, I'm going to start. I'll take the middle question about the need for education in the provider community about vaccine-preventable diseases in general, pertussis in particular, the availability of testing, when to test, appropriate therapy, appropriate use of vaccine. I think we learned a lot through the outbreak about the holes or gaps in knowledge in the provider community with regard to pertussis, and I think to a large extent Those have been improved because of the outbreak and the realization that we need better education, but I think that's an ongoing issue. There are many providers who have difficulty recognizing measles and mumps because it's not as prevalent as it used to be, so we need to continue to educate the provider community about those things. I'm going to let Dr. Fukuda address the issue of cost reimbursement because she's a practicing physician.
Can you clarify in terms of the cost reimbursement for delivering the vaccines, or is this specifically the PV
Well, there's
counseling?
that question. There's the question on the landscape that's different than the one that was being talked about today, and that is whether or not we're adequately reimbursing for vaccine. But the question was, if 2109 passes and becomes law, my organization doesn't have a position yet. We haven't reviewed it at that level yet. But the concern or the question has come up, well, what if parents then leave the school, go get an appointment with the doctor, takes 20 minutes to have a conversation, counseling session, then goes back to school, does not sign or gets vaccinated or whatever, but the reimbursement of the clinic or the doctor's time for the consultation?
Well, my understanding, first of all, and my peers have asked me as well, similar question, whether they're in rural or in urban practices. Part of our job every time you come in is the discussion about the vaccines when you're in for preventive care checkup anyway. So I would assume that most of these patients who are getting their care have gone to their providers and already had that discussion. My understanding is that 2109 may not necessarily require a visit, but a signature. And if that discussion has already occurred, then it may not be a 20-minute visit. To then, again, go through that discussion, because it should have happened, and that patient's chart should be documented that was discussed. It will then be the decision with each clinic in terms of how they're going to handle the paperwork, if they're going to ask for a fee or something else in terms of the paperwork for that. A lot of practices who fill out the school forms anyway, or camp forms. Sometimes I get 4 forms in one visit, but you can't do all at once, but it's for camp, and then the college one that needs bubbles filled in and everything you can imagine. And we decided to charge parents for a fee for certain forms. It's not onerous, but it's understanding that we need to be reimbursed. There are counseling codes. Unfortunately, that's another issue in terms of working with insurance and getting them paid. But you know, I'd like to reiterate, the form is not to convince those who have already made the decision, but really to educate those who don't have enough information or are opting out for convenience.
And to Dr. Tallarico for the third question.
So, as far as I'm aware, we don't have any information about whether parents who take PVEs for their children are immunized or not. And I think that raises a question, but it becomes a legal question. I do know that in other states that do not allow personal belief exemptions, that there is case law that talks about that actually where judges have ruled that parents who have not immunized are guilty of medical neglect for their kids, but not in California.
Just another question.
Okay, I'd like to thank everybody for coming today, and look forward to the discussion around this bill.
Thank you.